Our next speaker is Professor Stan Kutcher from Halifax, Canada. He will talk about international school mental health, global approaches, global challenges, and global opportunities. Who? I don't know how this works.
Forward, okay, backward, and the pointer. Perfect. Well, that was a wonderful, wonderful lecture. It's lovely to see our own discipline starting to catch up with our own brains. And now for something completely different. I just want to first mention that we are in the Why Mind revolution. This meeting gives us an opportunity to bring together an army of brand new people. Vision, competencies, and passion, and you can build on what some of us old people have done before, but you're going to do it better. You're going to have better tools, but your purpose and our purpose was the same: to have a better world for us, our kids, and our fellow travelers, because one of the wonderful things about this meeting is that we're all fellow travelers. There are no countries here. There are no groupings here. There are people who are all alike. We just tend to focus on the differences instead of the similarities. And Jair and I were speaking when we first got here, and I didn't realize, but Jair is actually a revolutionary. And he started to tell me about his revolutionary ideas, and I said to him, this is wonderful, because we're the same age, and I was also a revolutionary. And so Jair said, would you like to see a picture of me, that's a picture of Jair, in college, in university? So here is Jair in university. Siempre la revolución, huh? More or less. My team is a knowledge translation team. We can't do our work until Myrna's done her work and Joan's done her. We can't do any of our stuff until all that is done. So in some ways, we're always a little bit behind. I started my research career in neuropsychopharmacology and was always at the front end, and now I'm doing this work and I feel like I'm always behind. But it's the learnings that we get from the science that we then will translate into what we do on the ground. And I have turned from knowledge discovery research to implementation science. How do we get through that second valley of death from what we know in the clinical field to what we need to put in the systems field? One of the ways that we actually do our work is very different. I'm going to talk to you about schools and school mental health, and I just want to point out that we don't work in a research institute. We're not instituted away from everybody. But the people that we work with are educators, they're teachers, they're principals, they're superintendents of school districts, they're deputy ministers of education. They're the people who make the decisions about what happens in the schools. They're parents and they're young people. Because if they're not there from the beginning as we do our work, they are not going to be there at the end when we finish. So one of the most important lessons for young people like yourselves who are starting out, and if you're doing any implementation science, is don't do your science from an institute. Do it from the real world. Link from the beginning with the end users. Knowledge is not of value to somebody if they cannot apply it. and you must translate that knowledge into a format that they can use in its application. And we have young people that advise us on everything, and none of the materials we create for use in the schools are done without young people reviewing every single one of them, commenting and being part of our critical analytics as we do that. What I'm going to talk about is some definitions that, although we've known these have been outdated since the 1970s, are nonetheless heuristic in terms of providing us with a paradigm which is relatively useful because it's better than the paradigm we had before. Science is never about finding the truth. It's only about being less wrong most of the time. So this paradigm is less wrong than the one that was before it, but probably completely wrong to the one that's coming. But nonetheless, we're going to use this. I'm going to talk about how we can look at this globally. So this is a big issue. There are substantive data that, even with the problems in diagnosis that we've heard, that these are relatively similar in presentation in most places. Prevalences vary. But mental health promotion interventions may not be the same. They don't necessarily map out in the same way that illnesses or disorders map out. And that's a really fundamental difference and something that we have to keep in mind. So approaches to the promotion of mental health may actually be much more variable than approaches to understanding or dealing with interventions for care. Because site and context really matter. School environments are an example of the differences in site and context. If you are in a large city like Sao Paulo, not every school is the same. There are huge variations, and it would be really stupid to think that what would happen and would work in one site would automatically happen and work in another site. And I am going to now challenge one of the long-held strengths of the way we have done this, and that is the issue of fidelity. It may be that the issue of fidelity is actually not very helpful to us. Fidelity of approach, replication of process. Replication of process may not be the optimal paradigm for having great improvements or changes in different locations. So I want us to start thinking not about outcome-driven applications, to start thinking about outcome-driven applications instead of process-driven applications when we think about mental health promotion. This is a useful heuristic construct. We know about the spectrums. We know about the components. One can have mental health and a mental disorder at the same time. It is important to remember which of these areas we may be actually intervening in, because the approaches to them are different. And some of the confusion that I think bedevils our field of promotion is because we're not clear exactly where we're thinking. And I'm going to suggest some of the issues that we also have to think about from a systems perspective. From a systems perspective. Because these things that we come up with, these wonderful ideas, these great projects that show something, really are of little value unless they become embedded in systems. And it's the embedding into the system which is the key to making fundamental change to populations. We don't get fundamental change from populations of doing a project in one school. We don't get a fundamental change for population by doing a project in one area. They have to be embedded into the system. One of the ways to do it is think about a needs and rational response paradigm. We have to constantly think about return on investment. Because when we actually choose to put an implementation in place, not only is it our cost, but what we want to do is to ensure that the cost that we obtain actually is an appropriate cost. And when we decide to put in one intervention instead of another, we're dealing with an opportunity cost instead of an outcome cost. So what does this mean then for schools and adolescent mental health? Because that's the area that I work in. Well, we're all familiar with this data showing the onset of the diagnosis of mental disorders. And the curve takes off everywhere in the world that the studies are done. The curve takes off in the same time. And it's around ages 12 to 14. That's when the curve jumps. And we can look at it this way. This is the old DSM. This is the period of time, this is the time when the disorders become very manifest. It doesn't mean that they start there, we know that, but they become manifest there so we can help identify them at that point in time. And health and education we cannot separate in youngsters. We have created service silos in which education occurs in one silo and health in another, but they are not separable. They are completely intertwined. So why schools? Globally, we have chosen to help raise our children by putting them into extra-familial institutions. And we call them schools. And the purpose of schools is to create socially, culturally, and civically competent young people who will make an economic contribution. That's the purpose of a school. It's extra-familial institutionalization of growth and development. We actually, in our societies, have two institutions for young people. The first is schools, and the second is jails. Those are the two institutions we've created. And so it's very important that we focus on helping kids do well in the schools. It's a no-brainer. It's a no-brainer that the environment of the school matters. You don't have to be a rocket scientist or a prime minister to understand that. Well, maybe a prime minister has trouble with that, depending on where they are. The nice thing about schools is they're everywhere. Every country has them. The whole world has schools. If you're in Malawi, you're in Botswana, Bangladesh, Bulgaria, Boston, they have schools. And there's the famous quote from an American bank robber, George Bush. Sorry, to my Republican friends. I don't know if I have any Republican friends, actually. Why do you rob banks? Because that's where the money is. Schools are where the kids are, or where they should be. So if we want to make any kind of impact, any kind of positive community, civic, social, economic impact that improves our collective societies, we know we must start with our youth, and we know we must focus on the institutions where the youth are, which is families and schools. Even the Canadian principals know that. In a recent study of the principals in the schools in Canada, they all decided that mental health was good. I'm very pleased to report that. I would think that principals in most countries would agree. So, promoting health, addressing health problems, and addressing mental disorders are all really important opportunities for dealing with what kids come to school with. What they come to school with. So in terms of mental health promotion, it's a wonderful place. It's a wonderful place to create interventions which will improve outcomes not only in the short term, but potentially in the long term. There are lots and lots of challenges in that. Huge numbers of challenges. And we have to work our way through these challenges, but nonetheless, that's the place it needs to be. There is a huge and dynamic interplay. However, we need to keep this in mind, and there are these ideological camps, the one camp being fix the school, and the other camp fix the kid. But those are illusionary. They don't matter because they're both right. So we have to stop arguing about, are we fixing the school or are we fixing the student? When we look at mental health promotion programs in secondary schools, that's where the curve goes up. There are not that many of them. Most of the work is focused in the early years. That's good. That doesn't mean we shouldn't be focusing later. What we're seeing is a lot of the results that we see are not as robust as we'd like them. And people who like the idea say, oh, the glass is half full. People who don't like the idea say the glass is half empty. Here is a very recent review of interventions in schools. The impact was variable. Conclusion that the effectiveness of any intervention cannot be relied upon. Wow, that's sobering. Most interventions only worked sometimes, some did not work at all, and some were considerably more effective than average. One of the issues here is that there's a tyranny in the fidelity model, and that what we need to be looking at is replicability of results, not replicability of method. I frankly don't care how you do it as long as you get the good results. There are some clues in this morass of research. Integration into curriculum, multiple modalities of teaching, peer modalities, a huge area of different peer modalities. And one of the most interesting findings is that interventions done in schools by school staff are as effective in general as interventions that you as a psychiatrist would do in that same school, maybe better. Huge program in Australia, Mind Matters. Analyzed, reviewed, and the problem is that not that they didn't do good things, they did, but that people argued if it was the right thing to do. And it got back to this gap fighting about who's right. And so if you look back from the WHO document of 1994, what it actually addresses is a comprehensive approach, integration of all these different components. We have all sorts of very interesting single-point interventions. And frankly, in Canada, there are gazillions of studies all looking at one little thing in one school with one outcome. One of the most recent and very interesting ones published in JAMA Psychiatry was looking at prevention of alcohol use. Clearly, a very interesting topic. Effect size of 0.17, but it got published in JAMA Psychiatry. Right? So there are all sorts of CBT programs in schools. Who knows if they're done the same way? I don't know. And the whole issue of suicide prevention in school, the most recent review on this, shows that there's absolutely no impact of any program on suicide rates. Lots of activity in the scientific field, we call that Brownian movement. Screening programs have all sorts of other issues, very popular in some areas. The other big issue here, a very popular issue, are school-based health centers or health providers in school, fixing the kid, finding the kid and fixing the kid, providing services. And you know, there are some really good things. For many young people, they're easy to access because they're already in the school. If you happen to live in a rural community in Canada and you take a bus for an hour to school, when you get home, it's hard to go see a health provider. But if the health provider is in the school, it should be really easy to see the health provider, right? Makes sense. Wrong. Very interesting studies in Canada looking at mental health interventions in student health centers. First of all, 50% of students that were identified, over 50 actually, who were identified on a mental health screening in the school as meeting possible threshold for disorder didn't attend the health center. And of those kids that actually went there, only 13% were identified as having a mental health problem. So clearly, a lot of work needs to be done. Now, this is an interesting challenge. The traditional approach of mental health research in schools, which focuses on programs and interventions, has become stagnant. We have to have new paradigms into the organizational context of learning. The organizational context of learning. And I'm going to share with you how we've taken this construct, the organizational construct of learning in schools, to actually try to do something different. What I'm trying to focus on here is stop thinking about mental health promotion, prevention, and treatment as separate categories. Let's have a little bit more out-of-the-box thinking. And let's create a foundation to actually build a house of many rooms. Not a house of promotion, not a house for prevention, not a house for treatment, but let's build a house of many rooms. Let's modify the house to the needs of the kid instead of modifying the kid to the needs of the house. So what are the things that we need to do for the foundation? We have to embrace concepts of empowerment and self-management. Our medical colleagues use the Wagner model of chronic illness management as the core component of dealing with chronic disease. Note to us, mental disorders are chronic diseases. Critical and chronic incident self-management is the foundational stone for everything that we're going to do for intervention. There is a huge difference between trying to create a new system, changing a system, or tweaking a system. The costs are different. The political capital you expend is very different. The doability is very different. Cost low and return on investment high. Universal outcomes of knowledge, attitudes, and behavior. And again, don't get stuck in replicating the method. Strive to get replicability of outcome. And I just want to stress here, though I'm talking about schools, we know that this is only a small part of the issue. I had the privilege of leading the writing of Canada's National Child and Youth Mental Health Framework, called Evergreen. And we approached it, just like the NIMH is now approaching thinking differently, in a framework model, not prescriptive, but a smorgasbord of different components that could be adapted to different parts of the country, to different jurisdictions that would have positive outcomes. Not doing everything the same, but choosing what works in your location. So all these different things are important, and schools are just one of them. And this is a holistic pathway through care, beginning in the school area, promotion, prevention, intervention, right through the whole component, a community of direction instead of a single point of contact. I'm going to talk to you about what I think the common foundation for these components is. Okay, this is the foundation for building the house, and this is mental health literacy. You can't speak Portuguese, like me, I can't speak Portuguese, because I'm not literate in the language. You can't do math if you don't have math literacy. You can't understand geography or read a map if you're not literate in map reading and geography. So how can you understand our area if you're not literate in the area? This audience is full of people who are very literate. Most people in this world are illiterate when it comes to mental health. Most teachers in your countries are illiterate when it comes to mental health. Most policymakers, in fact, most ministers of health that I've known, and I know a lot of them, are illiterate when it comes to mental health. If we don't change the foundation, which is mental health literacy, we can do all the promotion, all the prevention, all the interventions we want. We're not going to make systemic changes because people aren't literate. Understanding mental health and developing the competencies to achieve and maintain it is part of mental health literacy. Understanding what mental illness is, regardless of the diagnostic system, knowing how to identify it, fundamental. Understanding stigma, changing attitudes, and understanding where and who to go for help, and what to expect when you get there. I remember many years ago a young boy coming into my office, he's about 14 or 15. He walks in and he said, "Hey, Dr. K, where's your couch?" Be one or the other. Now, he didn't want to come. I wouldn't want to go. You wouldn't want to go to see a mental health professional if your metaphor is one flew over the cuckoo's nest. No way. Right? Fundamental components for literacy. We can't build anything if we don't have the literacy. So, if we do literacy, can we empower people? Can we help them self-manage? Absolutely yes. If we do it in schools, can we tweak the system instead of changing the system? Totally. Totally. Some of my friends here know that I actually, in the last Canadian national election, ran for federal office. I lost. I ran for the Liberal Party, we did very badly. That's the party of Trudeau. People here know who Trudeau was? His son is now probably going to be the next leader, very good guy. And he has said to me and to others that he will put mental health on the national agenda. So we will get it there. But you know, he comes through that because his mother had bipolar illness. Changing the system is hard. Tweaking the system is easier. Cost low and ROI high? Yes. Yes. And this is the amazing thing about this. When you actually create mental health literacy as a model in schools, guess what? You don't have to change anything. Because what do schools do? They teach literacy. They teach language literacy, mathematical literacy, geographic literacy. They teach all of that stuff. It's called teaching. They do it already. Already doing it. Does every single teacher teach geography the same way? No. Does every single teacher teach math the same way? No. At the end, are people literate? Yes. Maybe it's not fidelity of process. Maybe it's replicability of outcome that we're after. The other thing is when you embed mental health literacy into a curriculum, you don't have to have a walk against suicide. You don't have to have a walk against stigma because it's not something out there, it's just there. So you learn it, just like you learn trigonometry or whatever you learn. So we created this many years ago, teachers training program to go with it, because when we started our field tests, we found out that the teachers were illiterate. How could someone who's illiterate teach? So we had to teach the teachers literacy so that they could then teach the students. And then we had to provide them with resources because they kept going out and coming to us and saying, look what I found on the internet. I'm going to teach my students this. And we say, oh my God, that's completely wrong. How can you teach a student? Because the teacher didn't have the skill sets to be able to choose wisely. So we created a committee of educators and mental health professionals to find resources and make them available electronically for teachers. It works. This is the teachers training program. These are some of our program evaluation studies. Knowledge goes way up in teachers, and guess what? The stigma goes down. The stigma goes down simply in training programs for teachers, teaching them to be literate. The stigma goes down. I had expected this to happen. I did not expect this to happen, at least not in that way. And doesn't matter where we do it, complete different group, different school board, same results. And everywhere we've done this, every single place replicates the same results. The knowledge improves dramatically, the stigma goes way down. That's in the teachers. What about the students? Well, some of our early field studies showed, yeah, doesn't matter what language you're in, same thing happens, good. And then this is some very preliminary data from a huge study, which is not from me, taking this, embedding the model in schools in the province of Ontario. Huge difference in students' knowledge and amazing change in students' attitudes just by studying the curriculum. No fancy program needed, no huge costs, no fidelity, same outcomes. So the takeaway is mental health literacy, we can do it. We can do it by using the same techniques that teachers have used for centuries. Teaching. All that we need to do is embed it in the curriculum, and they'll teach it, and the kids will learn it. And as long as the teachers have the right knowledge and the teachers have the right attitudes, that translates. In some places, the actual provinces in Canada, which are like states in Brazil, have put the curriculum into the provincial frameworks. It's in policy and it's embedded. Why? Because they have been at the table from the beginning. They have been at the table from the beginning. When the deputy minister sits at your table and she, in this case she, is responsible for the curriculum for the province, it gets in. It gets in. But in lots of other places, there are hundreds and hundreds, almost 1,000 schools now with multiple RCTs ongoing, and I've seen the early results of one of the large RCTs that look exactly the same. But that RCT is looking also at help-seeking behavior. Does help-seeking behavior in students change as a result of just having the curriculum? So mental health literacy is an approach that is foundational to mental health promotion, prevention, and interventions. And that's what self-management is about, being literate enough in your disease, in your treatment, in your diagnosis, and whatever else is good for you to be able to manage your own self. It allows for individual and group empowerment, fits like a hand into the glove. This is what schools have already done, and this is what they're doing. It's likely to be cost effective. I haven't studied it yet. I don't know. I can't tell you it is. But it costs peanuts compared to putting in a program. And the schools like it because you don't have to have researchers going in every day and researching. It's just doing it, and they just collect all the information because guess what? The teachers grade the kids anyway. They grade them anyway, and they grade their attitudes as well as grading their knowledge. Because why? Because it's in the test. No difference. It's able to be applied globally and locally at the same time. You don't have to make huge modifications because it doesn't require modifications. In fact, I'm going to end right here. One of the big projects that we have right now is in the country of Malawi and the country of Zambia. Two very, very low-income countries taking the curriculum, modifying the curriculum for the realities of the location, same stuff. And I'll let you know the outcomes in about 2 years. Thank you very much. You've been a wonderful audience.
Thank you, Professor Stan, for the wonderful talk. We have time only for 2 questions.
Thank you for your talk. It was wonderful to hear from this experience that we are trying to replicate here. I would like to know what instruments do you use to assess knowledge and attitudes in schools?
I was hoping nobody would ask me that question. We created our own assessment tools using a true-false I don't know option, because true-false I don't know works everywhere in the world. You either think it's true, you think it's false, you don't know. And having I don't know lets you not guess all the time. The attitudes, we took various combinations from relatively well validated attitude scales. The big problem is, and one of my PhD students is here, Yifeng Wei. Her PhD is on validating and creating valid instruments for measurement of mental health literacy. So what I'm sharing with you is instruments that have limited validity, but it's the best we have. And that we will have much, much more better validated instruments in about 2 years when she finishes her PhD. But that is the state of the art at this point in time.
Thank you. I'd like to thank you for your presentation. And you present a very simple, a change of paradigm, and it works. But I'm thinking here in Brazil and maybe in other countries, the more I think that the difficulty is to implement this not program but foundation in our schools become from the other mental health workers. Do you have problems to implement this idea because they are against mental or medical view of mental disease? Do you have problems to implement this?
The question is, do we have problems implementing this? Of course we have problems implementing this. We try to mitigate the problems as best we can, and one of the ways we mitigate them is by having developed this program and process with the participation of the major decision makers, which includes the educators, the kids, and their parents. So that gives us a great platform to move from. It's not just a researcher coming in with an idea or a program. And working with educators and spending a lot of time with educators, we have to do that because we think differently than they do. And we have a lot to learn from how they think. And our day-to-day experience is so different than the teacher in the classroom's experience. And if we can't understand that experience, if we haven't done the ethnographic understanding, we can't create the paradigms. Schools in Canada are bombarded with programs. In fact, one of the other projects that we have is doing a very critical analytical analysis. That's really good English. An analysis of existing programs when schools come to us and say, they're trying to sell me this program, should I buy it? And the answer is depends. It depends on what you want to spend your money on, how valuable, is it safe, is it effective, all these things. So the schools are bombarded with programs. They're bombarded with researchers doing things to kids or researchers doing things to schools. They like being able to take things which will make a difference that they are already doing. So, you know, if the mountain won't come to Muhammad, Muhammad's got to go to the mountain.
Okay.
Last question. Hi, Stan. Well, we know each other for a long time. I know you are a revolutionary also. I've been following your career along these years, and my question is very simple. Why did you want to be an MEP?
There should have been bourbon or something. I remember after I decided that I would run for political office, I called my mother because she's a conservative. She's right wing. So she's like an American Democrat. And I said, Mom, I've decided I'm going to run for political office for the next election. And there was this long silence. And I don't know if anybody here has a mother, or if you ever told her something, but a long silence after you tell your mother something is not usually a good thing. And then she said, "Are you crazy?" And I said, "No, I don't need a job. I have a wonderful, rewarding career. And seeing what happens in politics in my country and in the country south of us, it's a blood sport. But sometimes, in order to make the change that you passionately believe has to be made, you have to fight the battle." And I had two issues on my agenda. One was to try to create a national investment in early child development, starting at conception, so that every woman in our country would have supportive care from the time she conceived, not after birth, but from the time of conception. So if you are a person who is poor, if you are a person who is a single mom, if you are a person who has not been dealt the best deck of cards, you get somebody with you from the time you conceive. And that continues on. And there are a whole suite of interventions. We already have really good data about things that we can put in, but we're not doing it. So I got tired of people not doing what we need to do. And the second thing, Canada has a national health system, but it's a national health insurance system. But we don't have the capacity or ability to have the federal government, which gives lots of money to each of the provinces, direct where that money goes. And so the federal government every year gives millions and billions of dollars to each of the provinces for health care. No strings attached. And no federal politician is brave enough to challenge that, because the provinces all scream and shout. But what do they do with it? They don't invest it in mental health. So it needs a federal politician to say, yes, you'll get the money, but you have to at least invest this proportion in mental health. That's why I ran. Maybe we'll get another time in 3 years. Thanks for the question. All right.